Hi everyone, welcome to another fantastic and exciting Potrero Medical webinar. My name is Omar Khatib, I'm the Director of Growth. We will get started very shortly, but as you know, we have many people who log in from all over the world for these webinars, so we're going to give a few seconds, let everybody get logged in and settled in, and we'll get started. And I want to just double check are my speakers and special guests here. Dr. Schears, Barbara, are you there?
Yes.
Yes, Omar, thank you.
Wonderful, wonderful. Thank you all for taking some time to join us. We'll get started soon. How's the weather over there, Barbara?
It's summertime weather, hot, humid, and threatening to thunderstorm.
Definitely sounds like southern weather, definitely. All right, give a few more seconds and then we'll get started. Greg, how are things over in your part of the country?
You're talking about weather?
Yes.
We are in our 8 weeks of good weather of the year right now.
Oh,
and it's
definitely got to enjoy it, right?
Yes.
Wonderful.
It's a gorgeous day, sunny, a few fluffy cotton ball clouds in the air, and it's a gorgeous day.
Fantastic, fantastic. And, you know, again, I want to welcome all our attendees. I see many people piling in from all over the world, all over the country. Very exciting to see that. We thank you all for taking time to join us. So let's go ahead and get started. First, you know, before I introduce our moderator for today, a couple of housekeeping items I want to go through. As you see, we're using the On24 platform, so a lot of interesting things you can use, a lot of goodies, thanks to our wonderful speaker, Barbara, who provided them. So before we get started, here are the couple things I want to cover for the attendees. At the bottom of your screen, you're going to see multiple application engagement tools that you can use. Now, all these engagement tools, they're resizable, movable, so you can feel free to customize and move them around your desktop however you want. If you want to expand the slide space, you're more than welcome to do that. Now, as you know, we're going to have a short presentation. We're going to jump right into an exciting discussion and fireside chat, as well as an audience Q&A. So throughout the presentation, as you see to your left-hand side, that Q&A box, you can submit as many questions as you want. If you have any technical issues, submit them there. I'll be chatting with you through that area. And if you have specific questions for our speaker today, submit the questions there, and I suggest submitting them early. That way you can jump the queue. A copy of today's presentation will be sent to you, via email about a day or two later. So if you wanted to reshare this presentation, the live presentation that is with your team, and they can watch the video, you will have that. Barbara was also very kind to give us a fantastic resource list. So you'll see that green icon with the paper at the bottom. If you click that, you'll see various PDFs of the research papers that Barbara's going to reference in there. Lastly, you'll see our speakers' bios, so if you want to connect with them on LinkedIn, follow them on Twitter, or perhaps you have a specific question you'd like to email them, you can see their information there. Now, without further ado, let me introduce our fantastic moderator, good friend, somebody who I've had a lot of fun doing these webinars with, Dr. Greg Schears. So Dr. Gregory Schears is a professor of anesthesiology at the Mayo Clinic in Rochester, Minnesota. He is a pediatric intensivist and anesthesiologist by training and cares for both adult and pediatric patients in his ICU and OR practice. He has a long-standing interest in reducing patient complications, improving our approach to vascular access, and improving patient safety. In 2001, he was recruited to the Mayo Clinic in Rochester to start the ECMO service and was the medical director until 2017. Dr. Schears, I'm going to let you take it from here and go through the disclosures before introducing our speaker.
Thank you very much, Omar. Hi, everyone. Thank you so much for joining us. So again, in the name of proper housekeeping, I wish to disclose that I'm a consultant for Potrero Medical and also for Barbara Mclean. She's a consultant for Baxter Prismax CRRT, and for Edwards Life Sciences. So for today is a very important one and certainly has had a worldwide impact. We're going to focus in on the impact of COVID in a very large and well-known public hospital. And Barbara's going to talk about reducing risk and improving care, and also how some of the many innovative things that they've done there. I don't know if any of you have heard Barbara speak before. I have. I've actually gone out of my way to go to her presentations. She is phenomenal. And so if you haven't done it, go grab your friends and have them come listen, because she's going to blow your socks off. She always does an amazing job. She's very informative. I'm going to just highlight a couple things from her bio. She's got just a huge amount of experience, and she's truly a world expert in hemodynamic and other forms of monitoring. She has been in critical care practice for 40 years and has truly been walking the walk, talking the talk regarding advancing evidence-based practice. And she works for the Division of Critical Care at Grady Health System. She's a member of many professional organizations, including the American Association of Critical Care Nurses, Society of Critical Care Medicine, American Association of Surgery and Trauma, and has received multiple awards related to her excellent teaching, including an educational award by AACN, and has received the very prestigious Norma J. Schumacher Award for Critical Care Nursing Excellence. In 2017, she was the first nurse ever to receive the Joan Award from the Society of Critical Care Medicine for her contributions to critical care. And in 2018 was recognized as the most valuable player for the Grady Initiative in combating severe sepsis. Currently, Barbara has been intimately involved in the care of critical COVID-19 patients during this ongoing epidemic. She has guided teams in practice, assisted with development of strategies to limit exposure, and has facilitated family visitation at the end of life, which I hope she touches on towards the end of our presentation. As an educator, provider, and practitioner, Barbara has been committed to patient care and safety, critical care practice, collegial communication, and evidence-based practice implementation. And most importantly, every day of her personal and practice life are spent working towards improving care for patients and their families. So, Barbara, please, we're all looking forward to this. Take over.
Thank you very much for such a nice introduction, Greg. And thank you, Omar, and also Portrero Medical for inviting me to speak today. I'm very grateful for the opportunity. So I would like to just begin with a very quick overview of my hospital. This is Grady Memorial Hospital. And for anyone who has ever driven from the north or the west to go to the south, like to Florida or Disney World, you always enter what is known in Atlanta as the Grady Curve, and that's the merging of two interstates, one coming from the north, another coming from the east and from the south, and then also the east and west. And you will always pass Grady Hospital, and this is the original, or not quite so original, but the main Grady Hospital. We are slated for 960 beds. In December of 2019, we had a flood that took out 250 of our beds. We are also doing some major renovation projects at the time that the first COVID patient was introduced into the United States. We have over 140 adult ICU beds. There are 90 neonatal ICU beds, and we have a separate pediatric hospital, but most of our critical pediatric patients go to the general organization known as CHOA, and they go to the CHOA main campus at Emory University. Grady Hospital is very unique in that, first of all, it's a public hospital. We are responsible to the Fulton County Fulton DeKalb County Board of Directors, and we have 2 medical schools, prestigious medical schools, who actually send their residents into our practice. That would be the Emory School of Medicine and the Morehouse School of Medicine. Now, for those of you who work in an academic center, you realize that every week and every month your residents, fellows, and attendings change, and we actually have a change between the schools of medicine as well. So you can understand and admire that just like everyone else in the world who is caring for patients on the front line, heroes work there and heroes work here. And we're very appreciative that our hospital system has respected us and brought us up as the primary components of our team, the physicians, nurses, respiratory therapists, dietitians, and physical therapists, and chaplaincy, and all of the other programs that help to make this work when we're caring for critical patients. Today, I'm going to be talking about primarily some of the challenges that we've met, that all of us have met, in being frontline healthcare providers with patients in COVID-19, which is a complete shift in our primary practice. And I want to talk a little bit about what we've done within our system, some projects that I've spearheaded, but many more that have been implemented by others in my institution, because it's really a system initiative, not a personal initiative. And to talk about how we have introduced some remote monitoring and remote management in order to provide the best possible care while reducing risks for our staff. And then I want to discuss very clearly the role of urine output in understanding and evaluating and coordinating the effects of COVID-19 on kidney function, and the importance of accurate, timely urine output monitoring. And I'm going to discuss my experience with a particular monitoring system, the Accuryn Monitoring System in COVID-19 patients. And so to begin, on February 27th, the year 2020, I was with my husband. I actually was taking 3 days off, and we were on a trip to Selma, Alabama, to participate in the 50th anniversary of the March Across the Edmund Pettus Bridge for Civil Rights. And about 25 minutes outside of Atlanta, I received a phone call from our chief epidemiologist, infectious disease doctor, who said, "I think we have a COVID patient, and I'm wondering if you can come back and help us." Now, she was not talking about giving help for the care of the patient. Everybody in my hospital is uniquely prepared to care for acute and critically ill patients. She was really talking about the fact that I had been the clinical leader for our hazardous infectious disease unit, which was designed to take care of Ebola patients, and I have a fairly high expertise in personal protective equipment. So she wasn't asking me because she thought she needed me to provide care. She was asking me to come back and assist in training staff to care for a disease that we knew very little about and that we did not truly understand how it was going to be transmitted. Now, of course, we all knew about COVID at this point, but our very first patient was quite a young man, 24 years old, and he was presenting with profound hypoxia on 7 liters nasal cannula with a pulse oximetry that was somewhere between 86 and 88%, with a temperature that vacillated between 39.5 and 41 degrees Celsius, which is almost unheard of in an adult patient, with profound tachycardia, heart rate between 145 to 150, with extreme shortness of breath and tachypnea, his respiratory rate close to 45, and he had just recently traveled, lo and behold, to the state where my colleague Greg works, Minneapolis, Minnesota, to a convention, and he was there with people from all over the world. So he met our basic list criteria for possibility of exposure to coronavirus. So I came back and I organized a small team, and that small team actually took myself, another colleague who was on my hazardous infectious disease team, an infectious disease provider, and a nurse on the ward where the patient actually was transferred. That was a medical surgical step-down ward, an excellent ward at my hospital, but everyone was terrified. All the nurses, most of the physicians, the environmental services persons, they were very fearful, and we can all appreciate that because we really didn't understand transmission. We didn't really understand how this was going to blow up in our face, certainly, and we certainly didn't understand the evolution of the disease. So there was a tremendous amount of anxiety. Many individuals did not want to take care of patients that were under investigation. Those are called PUI, person under investigation, or with patients in the beginning who were confirmed positive. So one of the things that happened was that I myself, along with those 3 colleagues, we actually provided the acute care for this patient with our ultimate goal of trying to assure that he survived, and number 2, trying to ensure that he did not have to be intubated or transferred to the ICU. So remember, this was early on. We started with his nasal cannula at 6 to 7 liters. We then moved to high flow oxygen, and actually in the nighttime, actually put him on BiPAP. Now, all those things lost some preference during the transformation of our understanding of COVID, but this was really important with this first patient because we didn't really have guidelines yet. We really weren't sure of what was going to work and what wasn't going to work, and we were doing the best that we could to support him. But one of the things that I would say was really important in the beginning is we put him on an organized schedule of antipyretics, and we also placed him on a cooling blanket because his fever was so effervescent and he was so uncomfortable. And as soon as possible, we sat him up, stood him up, put him in a chair, and walked him around. So some of the things that we did early on actually became the hallmarks of care later. After going through a period of disagreement, it then became very much what we had done with that very first patient. So, but what was even more important was that all the team that worked on that unit, including the doctors and all other personnel, could see that we were going in that room fully protected and unafraid. And actually by day 8, our patient actually significantly improved, and I'm showing you a picture of him with me. This is me. I don't always have a mask. And this was after he had been cleared and on the day that he was being sent home. And I think what really happened here when we talk about that very first patient is that the number one role that we had was to actually control and assist individuals with understanding how to best prepare themselves to care for patients with coronavirus, COVID-19. So preparing the staff evolved from that in terms of developing particular protocols for the type of PPE that we were going to use. And as we all know, that changed. It changed certainly for us by the second week and then every day. Every day we would change our methodology of providing PPE. I myself, along with 3 members of my hazardous infectious disease team, we trained 1,800 persons in our hospital, most particularly nurse providers, techs, and anyone else who was interested, APPs, physicians, radiology labs, EVS, physical therapy. And we did that in addition to our regular work. So there were some weeks where we were working extraordinary hours because we were training people outside of our normal work times. And then checking back every day, again and again. Because in the beginning, of course, we, as we do in a public environment, we embraced everyone. And in the beginning, as we were developing some of our strategic plans, there were patients that were admitted. We tried to control the areas, but they were admitted into 4 ICUs, admitted into 3 wards, and especially as we were surging, we were developing domino strategies to care for those patients. One of the things we recognize, as I'm sure you do, and as you are probably still experiencing, is something that I would call uniquely PPE fatigue, which was, first of all, feeling like you've done it so much that you might shortcut some steps, which of course we know is dangerous. And secondly, just being exhausted every day after working 12 or 13 hours in your personal protective equipment, PPE, with an N95 mask. And we were actually covering our N95 mask to preserve the life of the N95 mask as well. So we oftentimes had double to triple covers of our N95, a face shield, a bonnet, shoe covers, double gloves, yellow gowns, and as we all know, our profound, intensive work with acute and critical patients and emergent patients was compounded so significantly by our PPE. But one of the first things that I actually worked with was understanding that the attire that we wear for our hazardous infectious disease unit is very limited. We have limited PAPRs, and wearing these overall, what people call bunny suits, which are hazmat level suits, actually induced very profound exhaustion because you became so hot even though you had some air circulation. So, and it wasn't necessary, or we believed so in the beginning particularly, to dress at this level. So we actually looked at utilizing soft bunny suits, face masks, face shields, bonnets, but not using PAPRs, because we were talking about outfitting 400 to 600 providers every single day. We just didn't have enough PAPRs for those individuals. We had to preserve PAPRs for profound aerosolizing procedures such as intubation. So you're seeing here the staff gathered together on one of our on our telemetry, on our step-down unit, and they are in relaxation mode, although you can see that many of them are dressed. You also notice that no one has gloves on. That's because they're not in the patient room right now. So when we, as we moved forward, oh, and I did want to share with you, I'm so sorry. I shared this with you, but I'm happy to share with you the basic procedure that we have for putting on your PPE. So that's called don, it's putting on PPE, and doff, taking off PPE. And this is our basic procedure. And what you would note, if you can see it well enough, and I'm very happy to share this with you, is the profundity, particularly in the taking off, of hand washing, which was a major implementation. And I'm sure just like every other system, every one of us could see that as we attained these higher levels of hand washing and real caution, that we actually saw our CLABSIs and CAUTIs drop so significantly because hand washing became such a central point of what we were doing. Now, as we moved forward, and I'm leaving many things out, so please forgive me, but as we moved forward, we actually began to really develop our critical care skills, our critical care methodologies. As we started to understand that COVID-19, with the SARS-CoV-2 virus, that what we were seeing was this exuberant inflammatory response that had a lot of similarities to what we looked at in sepsis and septic shock, and that we had a progressive lung dysfunction, which first presented with profound hypoxia that responded to oxygen therapy, that did not have loss of compliance, and then the evolution into the non-compliant lung, which has been referred to as CARDS, COVID ARDS. So severe hypoxia with a compliant lung to severe hypoxia with loss of lung compliance, those two different phenotypes of lung dysfunction. But correlated to that were these profound permeability changes of the capillary and histopathology changes, pathologic changes that we saw in the cell as the virus actually attacked the cell in its desire to replicate. What we also discovered at that time was that our traditional volume resuscitation for severe sepsis and septic shock did not actually provide us with the same type of outcome. So we quickly came to agreement that we wanted to keep patients euvolemic, not hypervolemic. And again, as we evolved and we began to understand the profound increase in blood viscosity, the consumption of clotting factors, and the significant profound micro and then macro coagulopathy, we started a tradition of aggressive anticoagulation in the more severe patient population. So over the days from February 28th to today, which is June 3rd, we evolved our practice from a sepsis ARDS model to a histopathophysiologic model, to really trying to understand what was occurring at a cellular level and looking at organ dysfunction and organ support very particularly and specifically. So there are many beautiful visuals that help us to appreciate the kinds of changes that we see with SARS-CoV-2. And you can see here that actually remarkably beautiful virus with all of its S-hooks, and that's what actually connects. And with that interruption and the stimulation of our inflammatory response, what two major effects that we would see early on would be pneumonia, as we all know, and hypercoagulability. That hypercoagulability, of course, led to further distal organ dysfunction. That includes the myocardium, the cerebral vault, the kidney, etc. Endothelial dysfunction, again, another hallmark that is shared with septic shock, that's profound endothelial dysfunction. And then the integration of therapeutic methodologies, mechanical ventilation progressing hopefully to ECMO if possible, but mechanical ventilation that actually was designed to overcome the low compliance. So that would have a mean airway pressure strategy, such as high PEEP or airway pressure release or pressure control. Doesn't really matter what you chose and what your protocols are, but the understanding that the type of ventilatory support actually put us at more risk for acute kidney injury. The myocardial dysfunction that actually was occurring. Sometimes we could see that you had thrombus in the coronary arteries. Other times what we saw was an inflammatory cardiomyopathy, but that myocardial dysfunction also progressing to acute kidney injury. And then with the endothelial damage, the acute microthrombi, cellular lysis, all of which affected the kidney. So it became really apparent to us that an early iteration was acute kidney injury, and how important it was for us as bedside nurses to have a remarkable capability to accurately evaluate one of the easiest markers, not a biomarker, but a functional marker of a decreasing urine output. So one of the ideas is to appreciate and understand that the level of requirement for the bedside nurse in terms of monitoring and acute vigilant monitoring had to be balanced with the idea of trying to limit exposure of staff in the care situation. So we were always trying to balance the highest level of monitoring and intervention with the highest attention paid to limiting exposure of staff in COVID-19 rooms, whether they had negative pressure or not, and always assuring that our staff was fully dressed adequately and accurately in PPE. So we really did change some of our oxygenation and ventilation strategies. Typically, we start patients with A to PEEP, but if the patient actually had by chest X-ray and agreement and PF ratio that we actually agreed that the patient had cards, we would start with a PEEP of 14 and titrate upwards. And obviously, that put a significant burden on the right heart and created some absence of arterial volume loading and arterial blood flow. In addition to that, the desire to avoid hyper or hypovolemic states and how we were going to do that, what tools we were using, how we could evaluate patients on an hourly basis to try to appreciate what their volume status was. We also looked at the introduction of self-proning to patients who were on acute care areas or who did not require intubation, manual proning, rotorest, and rotoproning. And the reason we choose rotorest and rotoproning is that we were trying to limit the amount of staff exposed during manual proning. And of course, self-proning is something that's a little bit easier. It's a very specific methodology that you introduce to patients who are on high flow oxygen or nasal cannula or non-rebreather mask. So remember, our number one goal, which is always very extraordinarily difficult for staff, was to assure staff safety. Our number 2 goal was to rapidly intervene, but you cannot rapidly intervene in a situation if you are not adequately and accurately dressed in your PPE. So we really looked at methodologies to enhance monitoring for preventative methods so that we could indeed reduce risk and exposure to our staff to the COVID-19 patient. So I want to show you a few things. I think probably everyone is doing this now. We were very, very, very early adopters, and I say thank you very much to my PharmD colleagues, and in particular our IT PharmD specialist who really assisted with rolling this out within 2 or 3 days. Nurses developed the method, and then they rolled it out within 2 to 3 days. You can see that we have our pumps outside the room. We have long extension tubing, and that long extension tubing is held up in the room utilizing a stat lock. Some units just use a basic hook. We are using stat locks, taking it across the room behind the ventilator and then to the patient. So again, we're requesting from our system to buy extraordinary extension tubing, and we don't have plugs outside of our room, so we also needed significant plug extensions, which allowed us to have our pumps outside the room. So you can see that this patient has 7 operational pumps because they're on multiple drips. The only drips we did not put outside the room were insulin and heparin. And we tried to avoid aggressive insulin therapy for the first period of COVID until we actually saw all the data about controlling hyperglycemia and the effect it had on mortality and morbidity, in particular to COVID-19. So I can talk more about that later if we have time, or if you have some questions about it, I can address that offline. And then I just want to talk very quickly. I'm going to bring up this other component of the slide. So we did an aggressive training program. It was an hour-and-a-half training program where the nurses would sign up, and I asked for 1 nurse from every unit for every single training, where we proned each other. So you can see here they're in what we call the Barbara sandwich, and then we prone this individual, and then we supine them. Every nurse actually experiences being the leader and also the patient. I used a lot of linen during training because I had to change the undersheet and the oversheets, of course, every time we proned someone. Then we proned a mannequin who was hooked to a ventilator, who had a PA catheter, central line, an A line, Foley, etc. And typically when we were proning the mannequin, who was very light, the mannequin would have a problem, like a disconnection of the A line, extubation, cardiac arrest. So after attending that, we developed a very large staff of prone leaders. But in addition, in the desire to reduce the amount of individuals at the bedside, so this person here is observing, we only need 4 individuals plus the respiratory therapist. That's still 5 people every time you prone, and 2 people every time you change to swimmer's position. We actually looked at the utilization of a rotorest bed to give steep lateral rotation. You can see here the patient is in a 45-degree angle, and our protocol reads to maximize to 62 degrees with a 10-minute pause per side. And we had many patients who responded quite well to that strategy. And then ultimately, we would move to a rotor-prone strategy, and utilizing the rotor-prone in a person who is a prone responder, we typically move to rotor-prone, despite the fact that it was more expensive, because that reduced the need for nurses and RTs to be at the bedside when you had an experienced rotor-prone user. And this is in the room of a COVID-19 patient. Over here, you might not discern that that's the arm of the nurse who is actually getting the patient's lines and ET tube ready for pronation, because the patient here is, of course, supine. In addition to that, we developed methodologies, not extraordinary, of writing on our glass doors and windows, and also using whiteboards for the nurses inside the room to express to the nurses outside the room. We could, of course, also use the intercom system, but that required that somebody was at the central station to answer the intercom. And we have great clerks, but they were running around getting supplies and doing many other things. So we wrote on our glass walls. We also had whiteboards in every single room. And we also significantly changed our methodology during intubation, first using a plastic tent, then using a plastic box, and using forms of plastic bubbles to reduce communication during aerosolization and during aerosolization procedures. And you can see here, this is another COVID-19 room, and you can see patients on CRT, monitoring, that's our EPIC, and our pump was inside this room. So you can see extraordinary measures that we were taking to try to develop strategies. But one of the biggest issues was, how do we actually monitor urine output? How do we do it safely? How do we trend towards KDIGO guidelines? I'm going to talk about those a little bit later. And how do we use urine output as a marker and a predictor of the reduction in flow through the kidney, and then correlate that to become a generalized marker, albeit not the greatest marker, but a marker of kidney function. So again, I want to remind you, this is a little bit more sophisticated. This is a beautiful article from the Journal of the American Society of Nephrology that was published this year in 2020 that actually talked about the COVID virus and the SARS-2 and how that combines and connects to different receptor sites, and that those receptor sites begin a whole domino effect that, as we've already covered, look like sepsis, may indeed be sepsis or septic shock, cardiac injury, lung injury, and then all of these multitudes of dysfunction that affected the kidney, not the least of which were dysfunction of the tubules of the kidneys, the distal, proximal, and loop of Henle tubules, the epithelial damage that actually often looks like ATN, which is nephrotoxic ATN, having rhabdomyolysis, and actually alternating the function of the podocyte, which is a really important role in kidney function, altering that podocyte and promoting microangiopathy. And remember all that microcoagulation and then collapsing of the glomerulus and ending in profound acute kidney injury. Now we know that acute kidney injury in and of itself by right, and when you have acute kidney injury, can lead to a very significant decrease in survivability. So very important for us to appreciate, and I'm so sorry, I kind of lost my control here. So you'll just have to excuse me for 1 second. Okay, good. All right, so as we consider and we move forward, then we say, all right, if we want to understand and care for patients and have an idea about what's actually occurring for our patients in terms of their dysfunction, we are going to look at a couple of different articles, and I unfortunately can no longer see that slide, so I'm so sorry to say that. But the first article that I've referred to, and that will be posted for you, is an article that actually shows us that accurate urine monitoring is something that doesn't actually typically occur in an ICU or an acute care setting. And there are many reasons that happens. And those reasons are not because nurses aren't doing the right job. Those reasons are typically because it is almost impossible to accurately monitor urine output. So very important when we're considering this as we evaluate our patients. So excuse me for 1 moment while I just get a little better control of the slide. And that, of course, is one of the issues with technology. But by the way, when I was in Haiti, I was known as Mclean MacGyver, because I would almost always figure out a way to overcome our problems. So when we look at this accuracy of conventional urine output monitoring, this was published a while ago in 2012, just to remind us that human factor and airlock actually can diminish the accurate and real-time, right now monitoring of urine output. So very, very important when we're evaluating our patients to have an understanding of that. And then to also look at this lovely paper from George Kramer and others, and Bruce Friedman is someone I've known for quite a long time. He was a burn intensive care specialist, is the inaccuracy of urine output measurements due to urinary retention. So again, related to the airlock strategy. Omar, I'm going to ask you to take over control of the slides. So we're going to go to slide 22, and I will.
No problem.
Okay, so go to slide 22. Okay, so when we're considering this, and we're looking at this relationship, very important to see this beautiful graphic that tells us about false oliguria because of urinary retention. Now, every one of us who works in intensive care are really, really aware that we see this quite frequently. In fact, when we see that patients are oliguric, we frequently will run and get a bladder scanner to evaluate whether or not that patient has bladder retention. And so you're looking at this false oliguria and then a surge in the airlock, and then all of a sudden the patient puts out a lot of urine, and then back again to a limitation in the urine output. Next slide, please. So we think about this as it relates to our traditional Foley drainage systems, and appreciating that when we're looking at the official Foley systems, that there has long been discussion that the Foley catheter itself does not completely drain the bladder. And because what our belief is, and we see it in a lot of other measurement systems, the belief is that that airlock is so difficult to overcome. And when you have an airlock in your drainage system, you are not able to drain the bladder. Next slide, please. So we think about this as it relates to evaluating patients. And again, this is in an older article from January of 2007. So I think we should be, on 24, good. And looking at the measured urine in the bladder. And you can see that when we're looking at 39 patients, 14 of them had greater than 100 cc's of urine in their bladder. And in the ICU, looking at 16 of those patients having greater than 100 cc's of urine in their bladder. So our idea would be to relate that to the airlock. Move forward to the next slide. Okay, so when we're looking at this next slide, slide 25, okay, so why is this so difficult for us to measure accurately? I think we should be right there on slide 25. This airlock, and what we're looking at is a device. It doesn't matter what device it is, but a device for urine collection that's probably being used in your hospital. And I'm going to use two red arrows to point to where the airlock is. So click twice to bring those red arrows up. Those red arrows are showing us the airlock. Now, I know if there are ICU providers in the audience that you appreciate that airlock and how it limits drainage and how we go into the room, we lift the Foley up, we pull the Foley down, we milk the tubing, trying to overcome the airlock. And we may be able to overcome it in the moment, but it occurs again and again and again. Next slide, please. So we're going to take a look at a video here on slide 26, looking at our video, which is showing the nurse holding the tubing up, and actually you're not removing the airlock, you're just changing the position of the airlock as it moves around. And now trying to milk that tubing. But look again, your airlock is moving back up the tubing, and the airlock must be overcome in order for us to drain appropriately. Go to slide 27. So on slide 27, what you're looking at here is the Accuryn device, which is actually overcoming any airlock that is in the complete Foley catheter and drainage system. So this is a beautiful technology utilizing a small degree of negative pressure to overcome the airlock. Next slide, please. And this last video clip, and unfortunately, I can't see the video clip. So, Greg, can you take over to discuss this video?
Sure. Thanks, Barbara. So, what Barbara was talking about is the active line clearance that the device has. So, the device itself is very clever, and it's solved several critical problems, one of which is this airlock, as Barbara mentioned. And what's happening here is that there's a small amount of air that is going forward to break the airlock, and it's actually avoiding any bladder trauma, so there's no disruption of the bladder endothelium, and so it helps protect the bladder and completely empty it. So she showed that prior study demonstrating, in comparison to, let's say, the group of burn patients when it's been studied, completely clear bladders compared to the standard bladder that can retain 300 or more cc's at a time. So I'll stop there and give it back to you. Are you there, Barbara, for slide 29? Hello, Barbara?
Hey, Dr. Schears,
Barbara?
let me message.
Okay, I'm sorry. I'm back. So.
You gave us back to you,
Oh,
Bar. You
sorry
worried
about
us.
that. So, so unfortunately, I got an urgent call and it disrupted me. I wasn't answering it, but it disrupted my phone. So if we just remind ourselves about acute kidney, are you good for me to go ahead?
Yes, please.
Yes. Okay, so if we just remind ourselves about intensive monitoring of urine output and the appreciation, understanding that intensive monitoring of urine output gives us a very significant key that helps us to understand and protect our patients from acute kidney injury. And in this very fine study from one of my colleagues, we can see a very significant component looking at our urine output monitoring and looking at it particularly with the relationship to AKI, stage 2 and 3, and then stage 3 alone, that intensive monitoring profoundly favors reduction profoundly favors an early evaluation and hopefully a preventative methodology for acute kidney injury. So I'd just like to remind everyone, you can always look this up on the internet, on Google. It's RIFLE. Always put in RIFLE for kidney, not just RIFLE. And that is standing for risk, injury, failure, loss, and end-stage disease. And of course, there are many components of this. We also have biomarkers for the kidney, but I'm focused on the easiest thing that we can do, and that's urine output monitoring. And so we look at urine output, and you see here, just in case you don't remember, that urine output is always a weight-based measure evaluated over time. And the significance, specificity, and sensitivity actually requires a vigilant methodology of monitoring the urine. And so when we look at the CDICO guidelines, again, stage 1, 2, and 3, urine output monitoring, we can see up here, urine output monitoring is a very important component. So in my institution, we use the Accuryn device that overcomes that airlock and provides us with a continuous measurement of urine output. And you can see here, yes, this is a COVID patient, also a COVID patient with cardiac arrest. And you can see that we are utilizing targeted temperature management as well as continuous urine output monitoring. Here's our Accuryn device in the real-time situation. However, the LED panel is not that easy for us to see outside the room. So in an attempt to reduce the exposure and risk, we actually are very fortunate to be the beneficiaries of an AccuTab. This is a tablet that actually projects the screen of the Accuryn device inside the room to wherever the tablet is outside the room. And you might remember, and so what you see here is my patient's total urine output since the monitor has been reset, 2 hours ago, 1 hour ago, and current hour. Their bladder temperature, and if you were monitoring abdominal pressure, it would be right here. Now this is a description, a beautiful photograph of the tablet, but now we're going to look at our tablet outside of our room. And you can see this is the COVID room. You know that because they've got the yellow bags hanging on the room. And you'll see here that I've affixed this, unfortunately, with just a rubber tourniquet tied to an IV pole. There is a very wonderful way for us to hold that on the pole, but this was a Mclean MacGyver methodology because I couldn't get the back on the pole, so I just tied it with a tourniquet. And this is the nurse who was caring for that patient, and this is me. I do actually survive without a mask, but right now you're seeing me only with mask. And you can see that I am tied to the pole right here. Now, in our patients, we did not use the adapter to connect temperature to our in-room device, so that could project to the out-of-room device, but it is certainly highly possible. So now we look at that patient, his total urine output in the last 2 hours, 58. He made 30 here, and he had 22, and then we had an hour where we were trying to adapt it, so we hadn't collected that hour, and then 7 in the current hour. And I've just given his actual temperature here that was not monitored because we didn't have the catheter connection. But what I want you to see is this beautiful deal. Every hour, how much urine he made every 15 minutes and the total of urine. And even more important is this line right here. This line is telling us what the urine output should be per hour to meet the KDIGO guidelines of urine output in mLs per cc. So for adult patients, it should be 0.5 to 1.0 mLs per kg per hour. And that's all been calculated here so we can see whether or not we hit the mark. When we were right here, I called all the attendings and the APPs and the bedside nurses over and said, I'm not suggesting what you're going to do, but I am suggesting that your patient does not have appropriate urine output. So that was followed, in this case, with a volume bolus of 500 ml, and what you saw was significant responsiveness to that bolus of volume about an hour and a half later. So what we actually could do was say, indeed, we thought the patient was hypovolemic, we gave volume, and the urine output actually increased. So that was really important to us because we were able to use this fabulous tablet outside of the room to actually tell us what our patient was doing every single hour, what urine output we actually wanted, and how our patient was responding to therapy. Now, that device stayed on him. He was already 7 days into the stay when we received the device. The device stayed on him for the next 36 hours, at which time he got discharged from the ICU without going on CRT, which was really happy. The last few moments that I'm going to just talk about here are really about the human touch, and the human touch that we apply and that we can never forget for all of us as providers, for the patients who come under our care, and particularly those who are in our intensive care units and our wards in isolation because family visits are not allowed. So we actually have a lot of methods that we help our patients and families. I think a lot of folks are doing this. We have iPads that we use for Facebook Live. We actually have phones that we put into biohazard bags and take in the room and hold them next to the patient's ear so that the family can speak. And my palliative care team, in conjunction with the intensive care team, have developed protocols for end-of-life visits. And those end-of-life visits, we allow 2 family members. They meet with me. I give an informed consent about coming on a COVID unit. We have some discussion about what they're going to see. And then I dress them as we dress ourselves and take them in the room. Typically, the visit is limited to 10 to 15 minutes. And I just had a visit yesterday. It was my 14th visit in the last 2 weeks. Many of our families don't wish to come because of the risk of exposure to COVID-19. But these are the most meaningful moments, I would say, in my 45-plus years career. These moments of being able to bring families in to see their loved ones and to say what they need to say and to have the best possible approach that they can to understanding what we've done for their loved ones and being able to say goodbye. We help our staff in so many ways. This is the picture of provided food in our break room, and we provide meals every day. There are meals provided for day shift and night shift on all the COVID units. There's also a moral support hotline, and a psychiatrist who visits every unit once a week and communicates with staff, talking about moral distress and methodologies to unload. We have meditation programs, yoga programs, many introductions of ways to try to assist our staff. But in general, our staff just says, I can't wait till I don't have to wear a mask, and I cannot wait until this is over. So I do want to remind you, all of us everywhere, we are hoping for the last patient. And here we are in one of our units. This was the last COVID patient in that unit, and this is not for peace. This is V for victory, and V to honor and remember the victims of the COVID virus. And now two of our COVID units, we still have 2 open, but 2 of our COVID units have gone back to business as usual. I want to say thank you to heroes who work here at Grady, to the heroes who work everywhere in the world, every day in caring for patients, and in particular, the superheroes during this COVID crisis, working against extraordinary circumstances, and for us, not actually improved by the riots and protests, because we're in downtown Atlanta, which makes it difficult for us to get through the crowds and get to work. I just want to remind you in summary that COVID-19 and caring for COVID-19 patients have created significant and profound logistical and safety issues that we don't see in other critical patients, and that our strategies of trying to decrease staff exposure and improve monitoring have to be balanced very carefully. And there will be times that the requirement for monitoring and intervention will overreach the reduction in staff exposure. But for us, never to limit our care, and also never to allow staff to go into a room unprotected. So we are really grateful for new technologies that help make accurate urine output a reality for us, so that we can look at accurate, real-time, right now urine monitoring and use that as a predictor, as part of the prediction profile to prevent acute kidney injury and the requirement for CRRT. I want to remind you about the Accuryn device, which overcomes that airlock through that mobilization, moving that air without bladder trauma to actually improve the evaluation of accurate urine output monitoring. And to also let you know that one of the components of this device allows us to do integrated intra-abdominal pressure monitoring, which is profoundly and critically important, not only in COVID patients who have capillary permeability and alterations and profound extravascular volume overload, but in all critical patients where that can occur. And in order for us to understand that way beyond what we can do here today, because it's a very full discussion as well, we will be offering an intra-abdominal pressure monitoring program on July 29th, 2020 with myself and my wonderful colleague, Greg, who took over just flawlessly while I was trying to fix my computer. And I just want to say to everyone out there who's given so much of their life and their love and their care, thank you, thank you, thank you. We all say thank
Barbara.
you, nurses, doctors, and all. Thank you. Thank you.
Barbara, thank you very much for an excellent presentation. It was very thorough, and you hit so many different important areas. I can't thank you enough for it. There's all kinds of questions coming in that I'm going to address in just a moment. I had a few of my own as well, and I'm wondering if we can talk about those a little bit. Clearly the pathophysiology of COVID with regard to the kidney is complicated.
Yes.
There are those components that are directly caused by the invasiveness of the COVID virus. And it also seems to, at least in some reports, set up shellcate in the kidney. And then there's also that side of it that's related to the care. And I'm specifically talking about how you're managing the euvolemia strategy, which is a tricky thing, as you know. What is euvolemia? And have you found the Accuryn device, because of its high resolution of urine output information, since you can, in your case, you put it down to like every 15 minutes, but it could even have a higher level of resolution if you chose. Are you using that as a tool to help judge that euvolemic state? Can you tell me more about that?
So thank you so much for that excellent question. So I do want to just, I would be remiss if I didn't really talk about this in a more generalized framework, to remind ourselves that our kidney is composed of two compartments, the first compartment being the glomerulus, which is driven by volume and pressure, and the tubules, which is driven by oxygenation that's delivered via blood flow. And that's why it's so complex, because when we lose arterial volume or arterial pressure, we limit flow through the glomerulus, which then promotes a glomerular ischemia that then leads to tubular dysfunction. But also, as part and parcel of COVID-19, is in particular the release of iron. So this is something that we call ferritosis. We see ferritosis very commonly in evolving COVID virus, that we see this higher level of ferritin, see ferritosis, and we may actually see some actual tubular dysfunction related to that. So in either case, we have, and there are many other pathways as well. We have these pathways which may be linked to high urine output, that would be acute tubular necrosis that's nephrotoxic from the iron that's been released, and also from dysfunction at the glomerulus. So we might see either a very low urine output or a very high urine output. So I would probably tell you that I think overall it is not a right now shift that happens when you give volume or you promote diuresis. Diuresis is much more rapidly responsive if I'm giving diuretic therapy, particularly loop diuretics, that I will see diuresis if it's going to occur almost immediately, whereas I don't necessarily see the renal response immediately. So I have to actually be watching my patients before they are completely anuric, before they have a significant increase in their creatinine. And remember that they only have to increase their creatinine by 50% from baseline for us to think that they're already in renal risk. So what that urine output monitoring allows us to do, and I would say that I am more interested, and maybe I'm uneducated here, but I'm much more interested in looking at directed response. And so when I'm looking at Q15, or if I was going to look at Q10 or Q5, it would be in directed response to something aggressive that I've done, like inotrope, or inotrope, assuming that I'm going to increase renal flow and renal output, or vasopressors, as I increase these vasopressors, looking to see if my urine output is decreasing. So I'm going to use that as a very early sign to tell me about the presence of renal volume and renal pressure. I can see that very early on in the variability, but I don't have longitudinal data to tell you of an absolute clear methodology that I would write into a protocol right now. I think that vigilance and understanding that if I'm well below the KDIGO guidelines, I have to do something now. So I'm going to give you 6 hours, and I'd like to do it even sooner, but at 6 hours, I feel we can clearly say, all right, I've had a small bump in creatinine, I've had a significant reduction in urine output. What next? My patient's hypotensive, I've added vasopressors. Now my urine output's gone down even more. Okay, well then I have to answer in some other way. And again, the complexity of COVID-19 and the profound complexity of kidney function married together make this a difficult process that we can't make strategically profoundly simple. But I think one point for absolute certain is that in adults as well as in children, because I know you already do that in children, we must monitor urine output in the prediction of what the ml per kg per hour should be, and we must seek to target that goal. And it might not be every single hour that we can target, but if we didn't need it in this hour, it's got to be made up for in the next hour. And so I really do believe that strategically combined with intervention, we can utilize this to actually evaluate our patient's response to volume. I think actually assuring euvolemia, not hypervolemia or hypovolemia, is extraordinarily difficult. It requires a lot of calculations, and it's still not 100% valid. So we use this as part of our tools to look at accurate, direct, real-time right now urine output with other methodologies to evaluate cardiac efficiency, cardiac stroke volume, systolic arterial blood pressure, and other items like that.
Thank you, Barbara. Yeah, I agree with you, and I actually had many discuss this exact topic. And there's a lot of value, I believe, because of the high resolution that one can get in a cc per kilo over X number of minutes, where interventions such as a bolus or a diuretic can give us insights into that, because I suspect that we'll see a tip, for, let's say, a normal renal function, we'll see a given reaction to a judicious bolus versus a kidney that may have some decline in GFR. So as you say, there's more to come, and it's a very exciting time because of this level of resolution that we have. It's kind of like the equivalent of going from palpating somebody's pulse to having an arterial line, or palpating their pulse and having a continuous ECG. So we're on that transition time where we've got a lot more data than we've ever had, and now how do we best use it to help patients? I have another question for you, which is, you were the first in the country to get the tablet, and you talked about a little bit the use of the tablet outside the room. And you had a nice example of a patient where you identified early on a reduction in urine output and helped to recover that patient quite quickly. What has the staff's response been overall to the tablet?
So we were really probably the first people in the world to receive the tablet, and we just got it last Tuesday afternoon. So the staff response thus far has been, hey, this is really cool. And we're very technologic. They were very happy to be able to monitor outside of the room. But of course, a lot of our really critical patients were in the rooms already so frequently. But what this actually allowed us in a much larger capability visual that's not down on the ground to have at waist height or breast height, to be able to look at trended data and to be able to look at this, at what we set was every 15-minute urine output per hour, and to be able to look at the goal of the KDIGO guidelines for mLs per kg per hour, or per minute or per 5 minutes. This was really something uniquely special. And I think particularly when I brought the APPs, the advanced practice providers, and the physicians around and showed them that, they had been vacillating about, well, maybe we'll just wait a little bit and see if the urine output picks up. And when we looked at that, and I said, I'm not telling you what to do, but I am saying we have to do something. If you believe a diuretic is going to work, let's do it, and let's see what's going to occur. Because, again, actually having a full evaluation that says we are absolutely euvolemic and absolutely mobilizing that volume into the systemic arteries in order to have an adequate glomerular filtration rate, we don't always know that. And so sometimes intervention is diagnostic. And so I said, let's do one or the other, as you've been discussing today, and now we can see the absolute response of the patient to the therapy that you've given. And I think that was extraordinary. And it was very, very exciting to actually see the patient respond to a 500 cc volume bolus that we gave very quickly, and to see that response almost immediately, not momentarily, but almost immediately, to see that response and to have validation that what we had done was in the right vein. Because the patient was actually venous hypervolemic, but arterially hypovolemic.
One of the things I want to and I forgot to do this at the end of the presentation, but this is a good time for me to insert this. I want to thank the Potrero Medical Company for sponsoring this event, and I want to give them some kudos here too. So because of clinicians like you, Barbara, who are out there, you know, battling the good battle to try to help these patients, and the company recognized the need to help support clinicians outside the room to give them that ability to monitor the patients better and help reduce exposure. They all rallied around this topic and raced to get out a quality product really fast. So I don't know if you knew that, but they focused all their efforts in order to try to help staff to have that extra tool at the bedside, or actually outside the room. It's quite a quality product for something that went together in weeks, and got it out there for people to use. So quite an accomplishment, and hats off to them to listening to the concerns of the clinicians and what their needs were. I wanted to, I know that we're going over time here, but I wanted to ask a question that certainly we have been dealing with, which is, how are you dealing with the mental strain of this? You know, for me personally, I can say it has had a huge impact on my productivity. You know, there was that initial part, you talked about this a little bit, there's that initial preparation, and there's the development of protocol, and of course that's a good. And then there's the, you know, compliance with that, and the interface with patients, and the fear, especially with some of us older clinicians, the fear of our own morbidity and mortality, and trying to do everything right and help our patients as well. And I'm fortunately, at least personally, I think I've gotten to a better mental state. But how have you guys been handling that? Because you have been just hunkered down and been battling intensely for a long time. How are you dealing with that?
Well, thank you so much for that question. And I'm speaking on behalf of all my colleagues. I typically am in a COVID room 6 to 7 hours a day, but they're taking care of patients 12 to 14 hours a day. So I would tell you that I think the physical stress and the profound emotional stress, particularly during the height, for us, the height of the virus, where we were having 4 to 6 deaths every 48 hours, and then sometimes 4 deaths in 24 hours, and then just the rapidity of turning the room over. We all know that in the ICU we're always walking a balance between life and death, but the amount of death that we were seeing and the amount of lonely death that we were seeing, in conjunction with our physical exhaustion and really trying to express to our leaders and our system, and my system really listened beautifully. I'm so grateful to them. But just the commitment of the staff to be in this extraordinarily difficult equipment, and then to be caregivers. We're all caregivers, and to actually have to disable families from visitation and to try to strategize ways that we could be with patients who were so critical and patients that were dying so frequently took an extraordinary toll. So again, I'm going to say that my system has offered multiple methodologies to try to de-stress, but quite honestly, I don't think for the majority of us who provide care, for those who provide care at the bedside, for me who provides consultation at the bedside, and I'm in the rooms a lot, but the caregivers are the ones that are really taking the burden of this. And when we talk about nurses, they're doing it every day, day after day after day. And as most of us know, people lost staff. In the beginning, staff were just frightened, and that was totally understandable. But I believe that most clinicians have stepped up to the plate, but I think that we are not going to know the results of how this has impacted us until this is all over. I would clearly tell you that I think the majority of frontline providers are suffering some PTSS, which would be post-traumatic stress syndrome. And I think that some of us get our toes dabbled in PTSD. We come home, we cry at a Coke commercial, someone dropped a glass, we yell, we scream, we cry, we have nightmares. And at points when that alarm went off in the morning, many providers were like, I cannot do this again. I cannot do it anymore. But I think part of what intensive care providers have is an incredible strength. And we know that we are needed at the front line, and we continue to come to the front line, even to the detriment of ourselves. I think we're going to see vestiges of this for years to come, And I don't think we actually know the depth of this envelope of sorrow and suffering that we've been inside of for these last 3 months.
Yeah, I totally agree. I think there's a lot of silent suffering going on here, and the impact is far-reaching in so many ways. So, Omar, I know you're out there. We're 15 minutes over, and there's so many questions. What do you want us to do? Should we bring it to a close? Do you want us to do a couple quick ones? What do you want?
Hi, Greg. Yeah, great question, Barbara. Thank you so much. Believe it or not, about 90% of all of our attendees are still on, so I think people, as long as you and Barbara are okay with it, you can answer a few more questions, and I'll kind of leave it to you when to close. But yeah, everybody's still on, and they're still submitting questions. So
let me do a couple quick ones here. So one question is, okay, so if this machine is continuously emptying the bladder, is there does this lead to a lower risk for CAUTI? And Barbara, do you have any experience? Have you seen any CAUTI when using the Accuryn device?
Well, I haven't seen any CAUTI in the patients where we're using Accuryn, and I think from a common sense approach, because of reduction of retention, I absolutely believe that it will reduce CAUTI. Greg, I'm not aware of any scientific papers that are out there at this time, but that's actually a really great question, and it would be something that we, perhaps, Omar, you may be able to answer as well, that Potrero may be actually evaluating right now. Greg, you might know about some evidence papers, but I am not aware of that.
Yeah, it's a work in progress. Exactly as you just said, you know, the theory is, and I think this is correct, that by completely draining the urine out of the bladder ureter system, you should substantially be reducing the risk of CAUTI. And what we've seen anecdotally is that there is a reduction, but you know it's an elusive thing because it's a hard thing to study, and that is definitely something that is desired. But logically speaking, it should significantly reduce the risk of CAUTI. There is an attempt to try to do a lab-based evaluation just to prove out the logic of this. But it's exactly what you said, and I was just curious if you've noticed a difference or not. There's a question here that when using Accuryn device, are the nurses required to also document intra-abdominal pressure because it's being recorded? You know, I can answer that. The answer would be no, unless it's required. It'll be that information will be available on the device, and if you the device has the ability to directly place information within the electronic medical record, so you wouldn't even have to physically document it. It can be automatically loaded into an electronic medical record if you have an interface like a capsule type of device. So from a documentation standpoint, there would be a reduction in documentation.
Okay,
Barbara,
so
did you have something there?
Yeah, I want to make sure that we have a bedside nurse answer here as well. Okay, so intra-abdominal pressure monitoring does require a special catheter. And so we've been currently with our COVID patients. They come upstairs, they already have a Foley catheter in place. We're using their existing catheter connected to the device. So that's why you didn't see intra-abdominal pressure on my patient, because we didn't have that device and we didn't think it was necessary to pull the catheter and place the new catheter for the patient. So that's the first thing. The second thing is every device that you have at your bedside in this current world, your ventilator, your EV1000, your PA catheter monitor, your Impellas, your balloon pumps, your Arctic fans, and your Accuryn, all devices, most devices, let me just say that are current and modern devices have the capability of communicating with your EMR, but the majority of them require a third-party vendor, like a capsule, that relays that information. So for many of us, I'm in a public hospital, and we have an incredible amount of equipment, but we don't always have that third-party wear that communicates from device to monitor. So while most of your devices are capable of integration, you do need to have methodologies for that communication to occur. So it doesn't happen naturally. It's something that you should always consider when you're purchasing devices, also talking about what kind of third-party wear can we purchase to communicate directly to the EMR.
Very good,
Mayo is
and all exactly correct.
Place. You're probably a pretty rich place, so probably all your things communicate, but a lot of ours right now, we're working on that, but right now we are documenting.
And I'll do one last question here, and it really speaks to the usability of monitoring technology like this for other types of ICU patients. So our focus here has been predominantly with the COVID crisis and monitoring for those patients. Do you see the merit in using this technology in other types of patients, Barbara?
So actually, I am very fortunate to be working with the excellent nephro-intensivist, Michael Connor. If you've ever heard me speak about renal function, I always bring up his name. We are work partners in kidney and all things urine. And so we have worked together on the development of a CRT transition in our institution and the implementation of early CRT, particularly for profound metabolic acidosis that's refractory. And Dr. Connor has been working with Protero to actually develop and understand utilization. So we've been using this device, the Accuryn device, in our hospital for almost a year. The issue that, in terms of our application, the COVID patient was related now to actually being able to monitor outside of the room in the COVID patient. Now, monitoring outside of the room is always of some benefit, but again, in the standard critical patient, it's not that difficult to walk into the room and look at your continuous urine output. But if you saw the circle that I put around the device that's at the bedside, you would notice that your information, you do need to look down at the information. You can get everything you need from there. What's beautiful about the tablet in all patients is that the tablet is displaying that information into a really large graphic form outside of the room. So on rounds, when you're doing your nurse rounds, your handoff, when your physicians and EPPs are rounding, your PharmDs are rounding, you can look at this graphical encounter on the tablet, which is going to give you the last day's worth of data and gives you information in trended data that you can actually see responsiveness to all the interventions. And I again want to remind you, so anyone who knows me knows that I'm very interested in understanding arterial volume and arterial flow, and that a lot of the work that I've done is with the increasing of vasopressor in the pursuit of blood pressure, that we often see a reduction in arterial volume and arterial flow. And you see that reflected very clearly with urine output. So if I'm titrating up on a vasopressor and I'm now outside the room, my patient's doing fine, and I look at my tablet and I see that urine output is reducing in response to my increase in vasopressors, I'm going to have some discussion about what else we can do to not only ensure blood pressure, but arterial volume, and in particular, glomerular volume and pressure in order to drive urine output and protect the kidney.
Yeah, absolutely.
So,
I can't overemphasize the importance of looking at the end organ effect, because people get focused on a given blood pressure, but then it's at the expense of end organ injury, and the kidneys are the ones that often end up taking a hit. So it's certainly, I think, having this level of resolution with urine output, we can see, just as you said before, the impact of our interventions and how we can better work our way through these very complex critical situations. I'm going to end this there. We're 25 minutes over, and Barbara, as always, you always knock it out of the park, so thank you so much for all of your information and excellent teaching.
Thanks.
And I also want to thank the Potrero folks for giving us this platform. And they're going to also allow us to get back together. It's July 29th to talk about intra-abdominal pressure monitoring. So thanks everyone for tuning in. And again, Barbara, you're just amazing, and I look forward to working together again.
Thank you so much, and thanks to Potrero, and thank you all of you healthcare heroes out there. Thank you, thank you. So honored to be part of this profession. Thank you.
Thank you, everyone. Have a great day. Again, if you wanted to share this broadcast with your team, go ahead and reshare the link. We'll be sending the on-demand version to you in a day or two so you can rewatch it with your clinical peers. Thank you all. Thank you, Barbara. Thank you, Greg. And have a wonderful day and week. Stay safe out there.